Thank you, Jonathan, for inviting me to talk about workplace-based assessments. I'm going to give you a UK view based upon the experience we've had with ISCP since it started in 2007. We're all familiar with the traditional approach that most of us of my generation went through with the apprenticeship, with a relationship with your trainer which probably was variable. You had to gain confidence when you started. And there was quite a lot of observation, particularly in your younger years, because of the way in which we worked. But there was plenty of opportunity to gain a lot of experience, some of it, however, fairly inadequately overseen, as we believe now, although there was diminishing supervision as you became apparently more competent. In other words, the boss allowed you to do the next case on the list. The feedback you had was limited probably just to that impression that you were making some progress. And we had to address the drivers for change which came about during the early 2000s with a combination of factors, most of which you've already seen in other presentations today, with the latter point being the development of a curriculum which was competence-based rather than based upon pure time and pure numbers experience. Now, the way in which assessment has evolved has been very much based upon trying to work out why you should be using it and what the principal purposes of the assessment are. The curriculum has defined standards at different levels in all of the specialties, and the workplace-based assessment is the key area whereby these standards can be assessed on a day-to-day basis. To do it properly, you have to make sure there's systematic and comprehensive feedback. And I think as surgeons, we probably are not very good at that, and we're having to learn that. There has been some improvement, certainly. And of course, the whole output, and we have a test of knowledge in the examination, which I'm sure Malcolm will go into in detail, is to make sure we can assess whether or not the trainee has developed the skills to function independently once they've completed their training. So why use them? What's the point? Well, they do focus what we do as between the relationship between trainer and trainee. It allows us to look at the curriculum, pick out those topics which are perceived by the curriculum writers to be important, to demonstrate that there is a progression in the skills that the trainee acquires, as well as documenting their competence against the standards which the trainer perceives are appropriate levels. It's obviously got the role in patient safety rather than as we did, doing operations perhaps for which we may not necessarily have been completely competent, but to the most extent we're able to do so because we're relying on skills we'd acquired purely from large numbers of experience. But it also, I think, allows us to pick up where the problems are occurring. And by having a structured approach with a workplace-based assessment, not only can you pick up the one who's not making progress, for whom perhaps an alternative career choice might be an option, but also allows you to pick up the surgeon who is never going to reach the standard that we have designated, and can allow, in fact, focused training to try and see if the trainee can improve on what is perceived to be less than satisfactory practice. Now, this, I think, is one of the key slides from the point of view of workplace-based assessments, and I think where we have probably got it wrong to start with. The whole point about them is to demonstrate a relationship between trainer and trainee with adequate feedback so that you can comment on whether perhaps errors in knowledge, whether particularly to give praise where the good bits have been achieved, so that it's a continual basis and it's assessment of learning, the formative way. It's opposing, I think, in a way of the summative approach, which is more assessed largely in examinations, but there are evolutionary phases where summative assessment can be done in the workplace, and I'll come back to that. I make no apology for just running through this. We all know this list of workplace-based assessments, but it allows picking up in the totality those specific issues pertinent to the individual tools that we've grown to love over the last few years. And I'm making reference later on about the newer descriptors of supervised learning agreements and the assessment of performance as to how these are beginning to fit into surgical training. The case-based discussion is there to assess the clinical judgment of the individual trainee seeing a patient and having the opportunity to discuss their findings, their approach to management, and it allows to assess the test of application of knowledge for the particular example that the trainee has seen and has had the opportunity to discuss in detail. I think this is something that we've actually got room for manoeuvre, and I'll show you why in a little while. The CX has traditionally been at a lowish junior level, where the assessment has been of the ability to take a clinical history and do a formal clinical examination. But I think it's more than that. It's been left at that relatively junior level, but then it's got a lot of opportunities for the assessment in practice of observation of the way a trainee goes about their professional approach, and I'll keep coming back to that word in this talk, the professional approach that the trainee adopts in their interaction with the patient or members of staff and colleagues, and the way in which they can use that, the judgment they're developing, and that you as the trainer can assess that in real time. It's also obviously important that you can make an assessment of an individual trainee's communication skills across the board, be that discussing a diagnosis, breaking bad news, taking informed consent, etc. Those clinical skills, I think, have probably been outshone by our tendency as surgeons to make sure that our trainees are competent with the technical skills. And the two key ones here, the procedure-based assessments, as well as the direct observation of procedures. And the PBAs have unfortunately been taken on in a lot of situations as, I'm not prepared to take this on just yet until I've done a few, so I'm quite good at it. They're there to produce information about progression, and also to allow an individual to make the trainer to make a global assessment in the totality of the way in which a trainee undertakes a specific procedure. The professionalism side is a much, much more difficult entity to measure. We can measure these other things because we can set the standard. You can have adequate descriptors of the way in which you expect a trainee to behave in an interaction, the sorts of descriptors of the steps they should be taking to prove their competence in an operation. And operations can be broken down into individual components. But this impression of not only their trainers, but also other related individuals with whom the trainee comes into contact allows a good impression of the individual trainee's behaviour. And this, I think, is where we've run into some problems over the years with not being prepared to take this on. And it's a very illuminating outcome when you see yourself being appraised for the multi-source feedback, because you do see things that you didn't think were existing about yourself. And it's extremely important, as I think we've learned, to get this feedback between the educational supervisor and the trainee to highlight those issues which you may not notice about yourself. Now, moving on to how you use the WBAs, this is, I think, where we've run into some difficulty. When ISCP started, it required significant faculty education, and this continues to be required. And it's one of the key issues that we in ISCP feel we have to reiterate on a regular basis. The two key factors, I think, are the provision of feedback and also the ability to demonstrate that there's progression. Now, feedback is difficult. We're not really very good, I don't think, at the terminology, because we have a job to sit down when writing reports or filling in educational supervisor reports for feedback. And what we're trying to achieve as we evolve ISCP is to give prompts with a terminology such as this, which allows you to guide the trainee on the way in which they could move forward, having undertaken a particular workplace-based assessment. I think it's crucial to make sure that there is this strengths and weaknesses being explained and recorded. The problem is, if you don't, you end up running at the lowest common denominator, and that doesn't give due credit for excellence. Interestingly, in a piece of work which Ian Eardley and his colleagues did in urology, he was looking at the level of feedback which was being given in trainees in urology doing both PBAs and DOPS. And you can see that there was some positive language being used, but as you went down, the pointer's not working, to suggest areas of appropriate corrective action, not very good. Probably because we weren't quite sure what terminology to use. And particularly when it's providing explanations of what you should be doing next. And I think that's something that we need to work on. The Evidence of progression is there, and this again is from Ian's work, looking at the experience of the ISCP in the first half of its iteration, going up to about 2010, which showed that there was a progression with the global score through the years of training out of a total of 4. So that as the training was progressing, they were making satisfactory progress, and this was outlined by these results from assessing of the PBAs. And as another example, some work done in the Eastern Deanery looking at ENT procedures, looking at the progression through the training levels. Here's a fairly simple procedure in ENT, a nasal polypectomy, and you can see of the levels that were being achieved, that in the early years, doing quite a bit at a relatively inexperienced and not with room for improvement practice, but as you got more senior, not doing so many, because by ST5 you'd reached level 4, so progression was being demonstrated. But then you look at a more advanced procedure, not much being done at the junior years, and as you became more senior, yes, there were more being done, but it took quite a long time, and not many were getting up to level 4. So by the end of training, there was some evidence progression was being made, but you perhaps had not necessarily reached full competence. And this is something that we picked up with ISCP over its, each curriculum now is into its 3rd iteration. We've identified that some of these more advanced procedures we're not able to get to full competence during the time available through training. That's not necessarily a bad thing. We've also done some work looking at the volume of use of the WBAs as recorded in the curriculum, and apologise for the numbers because it is a busy slide, and basically we'll be talking a bit more about this tomorrow, but this is the totality as a quantitative record of the numbers of workplace-based assessments done during 2011-2012. It's records of over 200,000 workplace-based assessments, and it shows the spectrum across the board of PBAs, DOCs, CBDs and CX, haven't included MSF or observation of teaching. The average number of WBAs a trainee was doing during that period of time was 40. And looking at the spread of WBAs, and this comes back to my point earlier about the use of the individual tools, this is by individual specialty with core, cardiothoracic, general surgery, neurosurgery, facial maxillary surgery, ENT, pediatrics, plastics, TNO, urology, that the green and the red are the two principal green and the purple are the two principal clinical techniques, CBDs and mini CX, and the blue and the red are the technical ones. And you can see that in core, there is more or less a reasonable proportion of the use of these tools in that early years. As you get more into the other specialties, however, there's this preponderance of over 50%, if not more like 60%, and 70% in TNO of the technical procedures. And I think we need to get that balance back so there is a due assessment of the more clinically based assessments as opposed to purely concentrating on the technical ones. That was by specialty. This is the same picture by the respective training institutions, by the deaneries. In 2011, it was decided that there would be needed to be an evaluation of the use of ISCP, and this has flagged up a number of issues, not the least being the need to review the way in which we're using WBAs. And this is highlighting issues around reflection, something that, again, we're not very good at recording, but I would put it to you is really the definition of what makes us professional, learning from what we've done. And so there's been a work ongoing about the way in which we've evolved these the WBAs. And I think this is, and I make no apologies, Jonathan, for pinching this from you, but basically what we've run into problems with is that we've taken on the WBAs as tests, using them in a summative format rather than using them in a formative format. And as a consequence, it's that point I made earlier about trainees using these inappropriately rather than on a routine basis throughout their posting. So the redesign has very much trying to allow the use by trainers with the prompts to identify those areas of good practice and those areas where development is required. And this not only comes from the point of view of instructing trainers how to use it, but also how trainees should be using the whole process of WBA assessment as they go through their postings. The name change has occurred in the last couple of years with an attempt to try and get away from the criticism that a lot of this was a tick box exercise. The downside has been that the forms have been very didactic and have been needed to be completed, and this is where there's been some criticism from trainers finding it very difficult to complete. And the definition of these two terms, of which it was slowly evolving, we're trying to work out in surgery how we best use these terms, where the SLEs are much more formative, and the assessments of performance are much more summative. Now, the analogy that's been cited is that of the driving lesson for the SLE and the driving test for the assessment of learning, of a summative basis. We've taken the view in a discussion within ISCP and JCST that, in fact, it's very difficult to have a formal assessment of a procedure-based assessment on a summative basis, because you can't really do that on a routine basis, on a one-off. To make a PBA work, you have to have those repeated throughout the timing of a posting and have that evidence presented at the annual assessment at the ARCP, and that's when the summative approach should be adopted. But it's trying to get back as well to this much more informal relationship between trainer and trainee, so you get that individual feedback on a more routine basis. I wasn't sure I put this one in for the initial slide about apprenticeship, but in fact, using it for another reason, surgeon is here, and these folk are all looking around him and perhaps thinking, well, is he any good? Has he been speaking to us properly? Has he behaved himself in this environment? And this is where I think the next stage is where we're moving on, is the ability to assess the non-technical skills, looking at how the individual behaves, their professionalism, and this is within the operating theatre, but it can be applied anywhere else, to make this commitment to understanding of how an individual is working professionally. And there's work going on with the Academy of the Medical Royal Colleges and the GMC, looking at general professional competence. And it's back to this point I made earlier about assessing the professionalism, those things that we take for granted of what we've learned to do, but in fact, they are the things that in the majority of circumstances, if someone is failing and falls foul of the system and has performance-related problems, results in needing to be assessed. And I think that rather than just having it assessed in a separate format, the move now is to bring these integrate within the WBA process. So in addition to looking at someone's knowledge and technical skills, you're also looking at their professional behaviour. So it's become, I think, the fundamental component of training. It allows us to make an assessment throughout the years of training and is complemented by the exams. It is still evolving, and I think we are moving away from the tick box approach by getting much more formative and informal approaches back to the mental, back to what we did to a certain extent, but in a more structured way. But I think also going forward, there's going to be a greater emphasis on the way in which we combine professionalism within the whole process of workplace-based assessments. Thank you very much.